Dr. Ramdas, how will this latest treatment and diagnosis affect my daily life?
So it'll depend basically on where they're at, how far terminal, what treatment they're getting, and as Dr. Moodley said, if they're on chemo, whether it's a palliative type of chemo we're giving them, if they're on radiation, are we palliating a brain met patient, are we palliating bone mets? You know, it depends. It's the type of treatment they're on and which stage they're on and how we're going to manage them. Look, for an example, if you're taking somebody who has brain mets, and is that patient still corpus mentis? Does that patient still have a good quality of life? Because ultimately, when we are at palliative care, our aim is not quantity but quality, because that's what we want to do. The treatment that we intend on giving the patients at this point shouldn't be to hamper their quality of life. We should try and maintain something that gives them that better quality of life, be it a period of 1 week to 1 month. It should be a good quality of life. So treatment will vary depending on what they're going to get, what type of treatment, whether it's radiation, whether it's chemo, whether it's endocrine therapy. So it's difficult to say how would that that will affect a specific part. It's all patient specific and treatment specific.
Can I come in? I just wanted to add something there. We have a patient at the moment, a gentleman with brain metastases. He's perfectly fine. The guy is well. He got a recurrence. She gave him more treatment. He's fine. So brain mets does not mean you're going to die now. It depends on the disease, it depends on the treatments we can give you, it depends on the characteristics, the biology of your disease. So don't make the assumption that brain metastasis means death now. It can, it often does, but it's not always the case.
No, I agree 100% with Dr. Moodley, and we've got Gamma Knife now, which is brilliant, and lots of patients are actually doing really well on that.
Okay, good. Chiara, I'm not sure who could answer this question, but where or how would one access the latest clinical trials and clinical research?
That's feasible.
Well, there are various mechanisms for this, right? So, for instance, if you lived in the first world, you can access the NCI website, and it actually has all the clinical trials that you have in one place. Okay. In South Africa, that is something that's being developed by the various societies, the oncological societies, so that all the trials can be put on one website that people can get. However, that is not presently available. So what you do is you phone the different units, you phone the academic units, and you phone the units in the area that you're in to ask them if they have clinical trials for your type of disease. And sometimes they do, and sometimes they don't. The clinical trials are governed largely by the interest of the doctors there. So you won't get, for instance, somebody having a trial in ovarian cancer when those doctors see, in essence, only brain cancer or colon cancer. So it depends on that doctor and the doctor's referral site. The academic centers are a good place to start, so you can look at the academic unit at Charlotte Makeke, the academic unit at Steve Biko. They're usually a good site. But the trial sites are not necessarily just in the academic centers. So you need to do some work.
Okay. Chiara, what complementary treatment would you recommend to a metastatic breast cancer patient?
It all depends on their symptoms. There's different things. If there's pain, there's various treatments like stress release and so forth. So it all depends on the patient and the symptoms they're experiencing at that time.
Okay, and what would be the role of cannabis oil in metastatic patients' treatment plans?
Okay, first of all, cannabis cannot cure cancer. This is the most important one. And it depends on the oncologist or the radiation oncologist that's treating the patient. If they are comfortable with the patient using cannabis for pain control, then that is something the patient can look at. But the problem with most cannabis products that you get is everyone's mixing some really amazing funny stuff in it. So it's also a good idea to make sure where you are getting the cannabis, if approved by your treating doctors, that it's reliable with no funny added ingredients.
The important thing about cannabis, it does a few things. It improves patients' appetites. It helps with nausea. It helps with pain relief. Okay, so those are the tenets of what it can do. It also helps in some of the side effects of specific chemotherapy agents. So if your treating doctor is up to speed with those things, then they'll know when they can use it and when it shouldn't be used. Okay. However, if you have somebody who is naturally suspicious, then they may tell you off the bat, no, we can't use any of these things because it interferes with our medicine. Some of that is true, and some of that is honestly we don't know, so we assume that is a default position. Okay, so it's important wherever you go to be able to have a frank conversation with your treating specialist and have, if the treating specialist cannot help or doesn't have the necessary knowledge to make that call, is to call on people who do this all the time. Okay, I mean, Kiara does this all the time where she checks this, she cross-checks with the disease entity, she cross-checks with the treatment, there are pharmacists that are able to help. So there are lots of these people that go into this with a greater degree, and therefore they can assist by saying, hang on a second, in patients who are HER2 positive, this is a problem. In patients who are getting this, maybe not this drug. High dose vitamin C, a problem under specific circumstances. See? So there is a requisite amount of knowledge that needs to go into that advisory capacity, instead of us just saying, no, it's all bad, so you can't have any of it. You know what I mean? So that's what often happens with doctors, because that's often our default position.
Okay. Anything else you guys would like to add?
Palliative care generally starts from the start. It shouldn't start towards the end of life, and we shouldn't leave it to the end, because it's a process. And it's no palliative care, people, it's a misnomer. We should never believe that's end of life care, because it's not. Every oncology patient should start earlier on, and it's a process where you go through. You also form relationships, you form bonds with people, and it helps the process get easier. It always does, and that's what I always think. Shouldn't start it too late.
Patients need to watch their supplements. Quite a few can interfere with treatments. They can increase bleeding risk. They can interfere with endocrine therapies. So just because it's natural doesn't mean it's better. And they should always check the interactions with whatever treatments they're on, or if they're having surgery and so forth.
Thank you.
Thank you.
Thank you.
Thank you.